So moving on to atrial fibrillation, there's 3 characteristics of an AFib rhythm that they've got to meet for it to be AFib. Number 1, there's no P waves. You don't have any P waves. Why? In atrial fibrillation. What's fibrillating? What? The atrium. There's a difference in a fibrillation and a contraction. That's why ventricular fibrillation is not good, because it's just quivering, right? This is the same thing with atrial fibrillation. So essentially what you've got is you've got a ton of ectopic foci that are trying to create a conduction, but they're not strong enough to create what we would call a wave of depolarization down. And so you've got all these little electrical cells that are just trying to fire, but the atria is just quivering. Every now and then, the conduction can kind of get in an axis, and it can kind of move on down and go to the AV node. But remember, what is the AV node's job? What?
Backup pulse.
Well, it will back up but what is its primary job? It's to hold up that conduction, right? But in this case, it acts more of like a gatekeeper, okay? Because all of this conduction, it may come down towards the heart, but if it's all quivering and just fibrillating, the AV node can't let every single electrical stimuli that hits it come through when you've got all these millions of cells trying to conduct, right? And so the AV node will, in really no pattern, allow conduction to go through kind of as it wants to. So another characteristic of AFib is that it's irregularly irregular. And it's one of the only rhythms that would be irregularly irregular. And why is it that? Because the AV node is only allowing certain conduction to go through, but it's not in a pattern or anything like that. You don't have the rhythmic pacing of a node. You don't have the rhythmic pacing of the SA node. You don't have the rhythmic pacing of an AV node. You got all of this quivering conduction in the atria, and the AV node kind of has to discern when it's going to allow conduction to go through to the ventricle. Because remember this, all the issue is in the atria with AFib. So what's the ventricle going to do to every single conduction that comes down? It's going to respond to it, isn't it? And it's going to contract, right? And so if I let every single conduction that's in AFib go down, my heart rate's just going to go haywire. So this is why I didn't want you to characterize your flutter waves as F waves, because your book also refers to this as an F wave. But I just want you to say a fibrillating baseline. The baseline's fibrillating. Now that's not a P wave right here. That's a T wave. Okay? So 3 rules that atrial fibrillation or 3 characteristics. No P wave. Fibrillating baseline. And it's irregularly irregular. Okay?
So the ventricles are only getting 1 conduction per QRS complex.
Exactly right. Yep. All right. So essentially what's happening here, like I said, you got multiple ectopic foci. See, before class even started, if I would have said ectopic foci, y'all wouldn't know what I'm talking about. So you've already learned something today. You got multiple ectopic foci just blitzing the AV node, trying to create a wave of conduction, but it's not really that great to cause enough of a wave of conduction for the AV node to allow it to go through. But the AV node has to act almost as a gatekeeper to what goes down to the ventricle. So, as it allows it at random, then you're going to have an irregular heart rate. Okay? Now, what you may have with it is an atrial fibrillation with a rapid ventricular response, And that means that the AV node is allowing a lot more conduction to go through, and the ventricles are responding to every single conduction. And then this is where you might start having issues, because this is where you might start seeing a really high heart rate. Okay? But for now, let's just... I'm not going to ask you to try to count an atrial rate on an atrial fibrillation. Because in reality, in order to count an atrial rate, you've got to have what? A P wave. There ain't none. It's a fibrillating baseline. Its rhythm is irregularly irregular. P wave, no. Can you get a PRI? No.
So just put absent on those? Or?
Yeah, that's fine. Or for P wave, put fibrillating baseline. For PRI, put not discernible, not measurable, whatever. NA, whatever. And then the QRS. So remember, where's the issue with atrial fibrillation? It's in the atria. So the ventricles, as long as they receive a conduction, they should look normal. Okay?
So when it says rate, you just do the ventricular Z variable, or do you count?
No, you count what's on that 6 seconds. You can count how many ventricular complexes you have on that 6 seconds. But in reality, if you ever have seen a AFib on the monitor, in the hospital or on a monitor, it's going to go from 60 to 110 to 80 to back to 110 to 112. Like every beat it changes, because it's picking up all this crazy electrical conduction, but it's only allowing certain conductions to go through to pace the heart, or to pace the ventricle. Alright? So here's an example. Why is this not flutter waves?
Because they're not.
They're not organized, right? They're not organized, they're irregular. Remember we said that for it to be a flutter wave, it's got to be organized and it's got to be regular. So this is... And it's obviously not ventricular fibrillation because I've got identifiable QRS complexes, okay? So this is essentially an irregularly irregular rhythm that I've got a rate of 1, 2, 3, 4, 5, 6, 7, 8, 90. I've got a fibrillating baseline for a P wave. My PRI is non-existent, and my QRS is about 0, 1, 2 or so. Just off of the one I'm looking at. And so I would call this atrial fibrillation. Alright? Let's see.
What would you say for the P wave?
Fibrillating baseline. Alright, let's see. This may not work. Let's see if it works.
The heart is a 4-chambered structure. The main pumping chambers are the ventricles, which rely on the atria to supply them with blood. Normal atrial contraction is smooth and organized and allows for the efficient delivery of blood to the ventricle. Compare this with the fibrillating atrium that quivers rather than contracts and is therefore unable to pump efficiently.
So here's something that you need to know, and you need to go ahead and learn this and remember this. AFib is the dysrhythmia that has the highest occurrence of stroke. So if somebody has a stroke, oftentimes they may have had AFib. Not always, but what is happening to the blood as the atria is just quivering? Yeah, it's clotting, right? It's coagulating. And so that clot may pass through and then occlude something. Okay? So you'll probably see a question that says, which rhythm has the highest incidence of stroke? And you're going to tell me the answer is AFib. Is atrial fibrillation always irregular? Yes. Speak it with confidence. Yes. Or true. Alright, so do y'all have this one in your packet?
Yes, sir.
This, I think, is the exact same one we just looked at. No, it's not. Yes, it is. It's the exact same one we just looked at. So my rate, I can only get a ventricular rate. My rhythm is irregularly, there's two L's. Irregularly irregular. My P wave, I've got a fibrillating baseline. My PRI, non-existent or non-discernible or whatever you want to say. My QRS, I think I said was about a 0.12. So we call this atrial fibrillation. Alright, y'all good? Y'all need a break? You want a break? Okay. I got 15:08. Let's be back at, y'all need a little bit longer than last time? 15:20. I'll give you 12 minutes this time. Yes.
What's up with that?
The air's working. It's humid in here. Alright. So let's finish this up here. Alright, any questions so far? So we've talked about what? We've talked about MAT. We've talked about PACs. We've talked about atrial flutter. And we've talked about atrial fibrillation. So at this point, we're walk, MAT, PACs, A-flutter. We're 10 rhythms deep into your dysrhythmias since last week. They will get easier over time I'm not saying that it's just going to naturally come to you, but they will get easier over time if you practice them and continue to practice them. And don't just turn straight to your answer key in your workbook, but practice them. Then test yourself. Alright? I've heard some folks say kind of like this with your rhythm strips, is that you struggle with them for a little while, then one day, like, things just kind of start picking up on them. You start picking up on it, picking up on it. But that really, what that is just from study, right? Practicing. It's not really a study, it's more of a practice with this, okay? Alright, so the rhythm may be chronic in nature with AFib, meaning that there's a lot of people walking around with AFib right now. They may be on some type of anti-dysrhythmic medication. One of the older ones is digitalis. We've kind of talked about that before. They may be on another type of anti-dysrhythmic. Cortisone is an example, and it's just a PO version of amiodarone. But there's several different ones that they may be on. But somebody that has chronic AFib, typically there's another type of drug that you will see them on. Carotid is one of them that you might for rate control. And it actually works really well with the Atrial, but there's another type that's not it's not really a heart medicine. Think about it. AFib makes you prone to what? Stroke. What causes the stroke?
Blood
Clots.
clots. Blood thinners.
Huh?
Aspirin.
Not aspirin, but anticoagulants. Maybe Coumadin or warfarin. Eliquis is one of them. But they're anticoagulants. So that's one of the things that if you see somebody is on that and then they're on another kind of medicine, Carotid, or some type of antiarrhythmic, then you could get a little bit of a clue that, hey, they've got AFib. Another thing about AFib is that we commonly don't want to convert it. Okay? If they are not hemodynamically unstable, or if they can sustain until they get to the hospital, we don't want to convert AFib. Unless it's something that we just, the term would be paroxysmal. You viewed it changing. Alright? If we just saw it on the monitor go from sinus rhythm to AFib RVR, maybe we might convert it if they were hemodynamically unstable. But more commonly than not, you don't want to convert AFib. Why is that? Think about what the atria is doing. If the atria is sitting here in AFib and you convert it and it suddenly goes from this to this,
Or at least a clot.
it may pump out clots. So you may actually increase the incidence of stroking. Hey, cool, your heart's in rhythm now, but sorry you can't use half your body. So again, you always think life over limb. So if somebody was in like an AFib with a really fast rate, we would probably convert that because they're not able to sustain that, right? But if they're just in AFib and they're perfusing well and all that, we're not going to convert that. Okay? So which of the following rhythms have sawtooth waves? Atrial flutter. Atrial flutter. Alright, let's see if this video works.
A cutaway view of the conduction system shows an impulse initiated in the sinoatrial, or SA node, that spreads to both atria and then activates the atrioventricular, or AV node. From there, the impulse passes down the left and right bundles of the ventricles. The split screen shows normal sinus rhythm on the left. On the right, an AV nodal reentry pathway is shown, in which the AV node becomes rapidly restimulated and the ventricular response is rapid.
What is that called right here, where it starts circling? What? It's not a rhythm. What is it?
Reentry.
Reentry. So this is AV nodal reentry tachycardia. It's in its name. We've got a short circuit at the AV node.
A cutaway view of the conduction system shows an impulse initiated in the sinoatrial, or SA node, that spreads to both atria and then activates the atrioventricular, or AV node. From there, the impulse passes down the left and right bundles of the ventricles. The split screen shows normal sinus rhythm on the left. On the right, an AV nodal reentry pathway is shown, in which the AV node becomes rapidly restimulated and the ventricular response is rapid.
Notice what's not really getting stimulated right here.
The corresponding rhythm strip shows a regular, narrow, rapid QRS complex. The rate is rapid because the AV node is restimulated cyclically. The QRS is narrow because the impulse travels normally down the left and right bundles of the ventricles. The external view shows a normal sinus rhythm on the left compared with a supraventricular tachycardia on the right, with the ventricle beating rapidly at regular intervals. Note the re-entry circuit around the AV node that enables it to be stimulated at such a rapid rate. Provided that the patient is stable, a first-line treatment option could be adenosine, which is given via intravenous push. The initial adult dose is 6 milligrams. Adenosine has a very rapid half-life and must reach the central circulation rapidly in order to be effective. This patient's blood pressure is normal. Adenosine acts on the AV node to block conduction. Note that in doing so, there is a brief period of asystole. The re-entry circuit was also blocked by adenosine, allowing for the resumption of normal sinus rhythm.
All right. So, supraventricular tachycardia rhythm. So, essentially anything that the heart rate's greater than 100 and they originate above the ventricle would be considered a supraventricular tachycardia. The term paroxysmal refers to sudden onset and or cessation. You used to hear SVT referred to as PSVT or paroxysmal SVT, but you really can't call it paroxysmal unless you actually witness it, right? A couple of characteristics about SVTs. They're going to be greater than around 150 rate. Typically, you're not going to see a sinus rhythm that's greater than 150, okay? A sinus tachycardia usually doesn't go greater than 150, all right? So with the SVT, this one that we're talking about here, is not necessarily the AV nodal reentry tachycardia. This may be just a atrial ectopic focus, overrides the SA node, and it just is spinning, but it's still going to kind of produce the same effects, okay? We're still going to have a really fast heart rate, okay? But you're typically not going to see a P wave with SVTs. So your rules with SVTs, your atrial rate and your ventricular rate's 150 to 250, but your atrial rate, typically, you're not going to be able to count it because the P waves are covered up by the QRSs. The ventricles are contracting so fast, even if the atria do contract, they're not going to be able to override it, okay? It's regular. So I told you about the P wave, so if there's no P wave, you can't typically get a PRI. The QRSs, because it's going so fast, your QRS complex is going to usually be very narrow. Does that make sense? Why? Because it's going faster, so it's contracting faster. And so QRS is a direct indication of your ventricles contracting, right? So if they're contracting faster, your QRS is going to be more narrow. All right, so your top rhythm here, there's 6 seconds. Do y'all have this one?
No.
All right, so your rate is 250. Can you see, from what y'all can see, does it look regular? It does. Can you see a P wave? That's not a P wave right there. So there's not a P wave, not a PRI. Your QRS is narrow. It's about 0.06 or so. But my rate's 250. I've got a narrow complex QRS. So what is this? We need to call it supraventricular tachycardia.
You
All
said,
right.
wait, the P wave is non-existent, and so the PRI is non-existent, right?
Correct. What about this one? What's my rate here? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17. So it's 170. It's greater than 150, 160. I still don't have a P wave. Well, I might have a tiny one there, but it's not enough for me to try to get a PRI or anything like that. And it's a narrow complex, so it is a supraventricular tachycardia as well. All right? Works the same way as if a sinus rhythm is 110, it's a sinus tachycardia. Or if it's 150 and it has all the qualifications of a sinus tachycardia, it's still a sinus tachycardia. The rate's just different. Okay? Let's look at this next one. Don't worry about the QRS being negatively deflected. Just treat it like a normal QRS. Do y'all have this one?
Yes, sir.
Alright, is it 6 seconds?
That was not.
No.
No, it's greater than 6 seconds. So let's start here. 1, 2, 3, 4, 5, 6. Alright, so we're going to count from here and here. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. So it's 150. I don't have any P wave. I don't have a PRI. I've got a narrow complex. So we're going to call this what? Supraventricular tachycardia. All right. What matters here is how the patient is reacting to that supraventricular tachycardia. All right. So several different causes. Stimulants are always going to be a big cause of anything that causes heart rate increases. Okay? Electrolyte imbalances, atherosclerotic heart disease is what ASHD is. My treatment for this, all right? So again, this is going to depend on, my treatment for a tachyarrhythmia is going to depend on their hemodynamic stability. And what I mean by that is essentially their perfusion status. I'm going to look at a few things with that. Blood pressure, obviously heart rate, mental status, skin color, temp. If you remember on the algorithms, I talk about the pink box of death. Is it causing, is the rhythm itself causing any of these signs? All right? Those are the pediatric ones, though. You'll want to look at the adult ones. All right? If they're not really causing any signs of poor perfusion, then we want to start with vagal maneuvers. You may also hear this called Valsalva maneuvers. I know y'all know what vagal maneuvers are. All right? What are some examples of how you would get somebody to vagal?
Take a syringe, blow it opposite end.
Yep. Get them to, one of my favorite ones to do is because it kind of gets them focused in on something and kind of gets their minds off of everything else, is give them a syringe, just tell them, I want you to blow as hard as you can and I want you to blow that plunger out. Of course they can't do it, but what's happening as they're pushing is putting back pressure in the larynx, which is putting pressure on the vagal nerve, which is stimulating the vagal nerve. What happens when the vagal nerve is stimulated? What chemicals released? Acetylcholine. What nervous system does acetylcholine go with? Parasympathetic. What does the parasympathetic nervous system do to the heart? Slows it down. Makes sense, right? Y'all have learned a little bit. You got your money's worth at least. One thing that they mention here is a carotid sinus massage. We don't teach y'all how to do carotid sinus massages anymore, but your carotid sinus is right in here, and it actually has some baroreceptors that would stimulate the vagal nerve, okay? And used to, we would go and we would get on the carotid and we'd start massaging it down, and it would actually stimulate the release of acetylcholine. Problem is what also is stored in older people's carotids?
Blood.
What blood? Yeah, definitely. But what? Plaque. And so you get real aggressive, you could cause plaque to rupture off, or I'm doing one of them and it ain't working. So wonder what happens if I just sit here and rub both of them the whole time. Well, they're going to fall out, right? Because your carotids is sending all the blood to your brain. So, anyways, the best way, get them to bear down, cough against the closed glottis. Some folks say, well, tell them to act like they're going to poop, bear down, but old people have accidents sometimes, and it just takes one time where you're like, I'm not going to tell you to do that no more. But our treatment is always going to be, remember, I told y'all about treatments. I think I was telling y'all about the treatments where you've got really 3 types of treatments for your arrhythmias. You've got in this order, it really should be non-invasive. You've got pharmacological. And then you got electrical therapy. So your treatments for every single cardiac arrhythmia that you have is going to fall into these 3 categories, okay? So, again, if they're hemodynamically stable, we've tried vagal maneuvers and they didn't work, then we can move to drugs, all right? In this case, adenosine is one of the drugs that you may consider. Adenosine, write this down, remember it, adenosine only works at the AV node. So in reality, adenosine is typically only going to convert an AV nodal reentry tachycardia, which looks just like any other SVT. But what adenosine does is, remember the short circuit there. So what adenosine does is it actually hits that short circuit and it slows that conduction down so that another conduction from the SA node can come down and then it can dissipate. And thus it closes the short circuit. Okay? So your dosage for adenosine It's rapid IV push. Have y'all learned about adenosine yet in cardiology?
No.
Alright, so adenosine, the first thing you want to do with adenosine is make sure you've got a good patent IV. Go ahead and have some fluids flowing with it, okay? You want to get the port that's closest to the heart. And then your adenosine, your dosage would be 6 milligrams. Your first dosage would be 6 milligrams, rapid IV push, followed by 20 milliliters of flush. They told you why, but why do you do it rapid?
Because it's got short half-life.
Very short half-life, and so it's metabolized very quickly, so you want to get it to the heart as quick as you can. Now, what they said that one of the effects of adenosine, if it works, is going to be a period of what on the monitor? Asystole. I've had people tell me that have been converted chemically with adenosine, and they've also been converted electrically with synchronized cardioversion. And I've had people tell me that it's a much worse sensation and feeling to be converted with adenosine versus being shocked. So when you give that drug, warn your patient, hey, this is not going to feel good. Yes.
I had both of them.
You had both of them? Which one was worse? Shock?
The adenosine for sure.
The what?
The adenosine.
Did
for sure.
So you personally had it?
Yeah, I had the SVT growing up.
Oh,
And
wow.
then I had an ablation.
Oh, you did?
Mhm.
Interesting. And so the adenosine, the chemical cardioversion was worse?
Yeah.
I've heard, and a lot of people say it's because it doesn't feel good to be shocked, but it's over. Like, you get shocked and then it's over. What was your experience with it?
It like paralyzes you.
Really?
And then, but it feels like real hot.
Wow. I couldn't imagine. I've been called every single name you can imagine shocking people. Other drugs that you might consider using in this algorithm would be Cardiazem, or what's another name for Cardiazem? Deltazem. Now your standard dosage for Deltazem nationally is a little bit different in your Alabama protocols. Alright? Y'all need to understand that you don't learn Alabama protocol dosages in paramedic school. You'll learn them while you're out there, but you learn national dosages in paramedic school because y'all are taking national registry, okay? 0.25 milligrams per kilogram is the typical starting dose of Deltazem.
Can you spell that?
No. Let's see.
You said the other was called Parkinson.
They're the same. D-I-L-T, Deltazem, I think.
D-I-L-T-I-A-Z.
Yeah, something like that.
It's on the next few slides.
And what's that for again?
So Deltazem is a calcium channel blocker. So it will slow down contraction and does slow down rate. It works good. It has AV node properties, but it will also work in atrial tissue as well.
Can adenosine mess somebody up if, say, they're not having SVT?
So typically what you would see if you gave somebody adenosine that they're not in SVT, and especially if they're not in like a reentry, like an AV node, is you would see the rate flutter way down, and then it would just come right back up. So in reality, I usually don't say this early on, but adenosine actually could be used as a diagnostic tool. Because sometimes if somebody's in atrial fibrillation with a rapid ventricular response and their heart rate's 170, 180, we know that one of the baseline characteristics of AFib is that it's irregularly irregular, right? But when you've got a rate that's 150 or 170, 180, it's really hard to see those irregularities. And so it's like you may actually think it's like an SVT. Well, AFib, RVR is not going to convert with adenosine because AFib is ectopic issues and not necessarily reentry issues, okay? So you typically use a antidysrhythmic, amiodarone or something like that. But you can give adenosine and you can get the heart rate, if it doesn't convert, you can give adenosine, the heart rate will slow down, it'll flutter down to a real low rate, And when I say real low, I mean like if it's 170, it may flutter down to 70 or 80. Like it's not going to go crazy. And you'll be able to actually see what the underlying rhythm is, and then you'll know the route you want to take to treat it from there. Does that make sense? So it typically isn't going to like kill somebody, like just send them straight into a systole. Typically, it's always going to slow conduction down at the AV node. But if you've got a regular conduction going through the AV node, typically it flutters down and then it comes right back up. All right. So a very important question to ask with your tachycardias: are the symptoms being caused by the tachycardia? Because if they're not being caused by the tachycardia, I'm not going to pull out all my cardiac drugs. I'm going to do just like I would do for sinus tachycardia and do what? The underlying cause. If the symptoms are being caused by the tachycardia, treat the tachycardia. If it's a supraventricular tachycardia with a heart rate of 180 that's not allowing for ventricular filling, it's not allowing for good cardiac output, thus causing that patient to become hypotensive because their heart's going so fast, then we're going to treat the tachycardia, because that is the reason why their blood pressure is crap over crap and their altered mental status, right? But if they're hypovolemic, very dehydrated, and their heart rate has increased because of a compensatory mechanism, but their blood pressure is really low because they're dehydrated, then I'm not going to give them drugs to treat the increased heart rate, because that's just a byproduct of what they're in, which is hypovolemic shock. I'm going to give them fluids. Does that make sense? So you want to treat what's causing the symptoms of that patient. If the tachycardia is causing the symptoms, treat the tachycardia. If there's something else that's causing the tachycardia and in the same turn is causing symptoms, you've got to treat that something else. It's kind of like your H's and T's in your cardiac arrest. Okay? If they are hemodynamically stable, we can try vagal maneuvers. We can also try one of our first line drugs for narrow complex? Adenosine. What's my initial dose? 6 milligrams. Rapid IV push followed by 20 cc's. My second dose, if I give a second dose, would be 12 milligrams. So I double the initial dose, still flush it very fast with 20 cc's. I could also consider giving, what was another drug? Cardizem or deltazem. You could also consider giving amiodarone as well. Usually you give amiodarone for your wider ventricular rhythms. We're not in that right now, but we'll talk about it. If they are unstable, what we mean is hemodynamically unstable, showing signs of poor perfusion, pink box of death stuff, our very first treatment is going to be synchronized cardioversion. All right? This is a little different than your bradycardia algorithm. Your bradycardia algorithm, no matter what, you typically give atropine first. All right? Now, I have seen more of a shift towards kind of the same thinking as this if they are very unstable. Who was, I think it's Thomas, you're telling me that y'all paid somebody the other day and they just totally bypassed atropine and all that because they were unstable. But if you follow the algorithm, they're going to give atropine first. And then we're going to move on down to dopamine or pacing. But if you follow the algorithm for your tachycardia, you've got to determine, are they hemodynamically stable or unstable? Hemodynamically stable, the first thing we're going to do for them, they're stable, is what?
Bear down.
Vagal maneuvers. Then we're going to consider drugs. If they're hemodynamically unstable, the first thing we're going to do is synchronized cardioversion. So, vagals and drugs, if they are hemodynamically stable. Shocking if they're unstable. I've heard a lot of physicians say they would really rather you just go straight to shocking because it's definitive, it works. Most of the time, it works. 60% of the time, it works every time.
You said, what was the half-life for Adenosine again?
Short.
You don't know the
No.
exact?
Like really short, like seconds. Alright, and so this slide here just says what I've already told you. All right, so here's your algorithm here. This is the 2020 updated algorithm. Well, updated, it's the 2020 algorithm. All right, this is the pink box of death I keep referring to. So let's start at the top. We put them on the monitor. We saw that their heart rate is greater than 150. We've determined that the heart rate is what is causing the symptoms. All right, so we're going to continue to follow. If they're hypoxemic, meaning if their O2 stat's less than 94%, we're going to give them O2. Obviously, ABCs, 12 lead, IV. All right, so we get on down here. So we need to determine, does this tachyarrhythmia, is it persistent, meaning that it's not paroxysmal, it's not changing, it is fast and it's staying fast. Is it causing any of this? Hypotension, acutely altered mental status, signs of shock, ischemic chest discomfort, acute heart failure. Also referred to by me as the pink box of death. All right? Now, that is not a medical term. That is not like, I just use that to help you remember. But when I refer, because I can't remember all those all the time, so I'll say pink box of death. So, if the answer is yes to any of these, it doesn't have to be all of these, it's just one of these, then we need to scoot on over this way. Alright, notice here, synchronized cardioversion. What you need to determine though, even at this point, is it a wide complex or a narrow complex? You will have determined that by now. Okay? So, for synchronized cardioversion, notice we're saying yes to the pink box of death. We want to consider sedation. If it's a narrow complex, we could go ahead and consider adenosine if we wanted to, but let's just go ahead and shop it. Alright? Now, it says, if you notice here on the algorithm, synchronized cardioversion, refer to your specific device's recommended energy level to maximize first shot success. So, I'm going to, we've told you these before, but I'm going to tell them to you now. Now you need to know, okay? So if it is a narrow complex, regular rhythm, so this is going to be like SVT, AV Nodal Reentry Tachycardia. My sync dose is 50 to 100 joules, okay? If it is a narrow, complex, irregular rhythm, this is going to be your AFib, RVR. You're going to go 120 to 200 joules, all right? And if it is a wide, complex, regular rhythm, this is going to be your VTAC with a pulse. And it's going to be 100 joules. Okay? So we shocked them. Refractory, remember, means what? Not responsive. So we need to consider underlying cause, or we would increase our joule dosage. We may consider an antiarrhythmic drug. Okay? Going back over to my pink box of death. I answered yes, I'm going to cardiovert. I answered no, is it a wide or narrow? If it is a narrow complex, notice here, vagal maneuvers, adenosine, beta blockers or calcium channel blockers. I told you one of the calcium channel blockers was diltiazem. One of your beta blockers is Sodalol. Sodalol is a beta blocker that also has class 3 antiarrhythmic properties. Other beta blockers you may see, maybe labetalol is one of them.
Can you scroll down just a little? So we can finish getting Jules in the last one. Thank you.
Now remember, I sent these algorithms out to you guys. So, am I on your way?
So this algorithm was with that first algorithm that you gave us last week. Is this algorithm with that other algorithm that you gave us with us?
Yeah, that's all packed up.
There's like 5.
Huh?
There's like 5 of them.
Alright. And then if all else fails, get an expert. Get somebody that knows what they're doing. Alright. Other dose you need to know, amiodarone. So if we give amiodarone, typically we give amiodarone in our Y complex, or our VTAC with a pulse. You can give it for your narrow stuff too, but amiodarone, your dosage is going to be 150 milligrams over 10 minutes. So what you're going to typically do with that is your amiodarone bottle is in a 150 milligram vial. You'll just get you a 100 milliliter bag of fluid. Technically you're supposed to pull, I think it's 150 per 3 milliliters. Yeah, your amiodarone, it comes in 150 and 3 milliliter if it's in the vial. So I would take my 100 milliliter bag. Technically I'm supposed to pull 3 milliliters out because I'm replacing it with this. And then that'll give me 150 milligrams and 100 milliliters. And I'm going to take this over 10 minutes, so I just do 10 milliliters a minute. I'd set my drip rate to 10 milliliters a minute. Okay? Pretty simple. You may also see, and it's not on this algorithm, but you may also see lidocaine given for like VTAC with a pulse. Now, we haven't gotten to VTAC with a pulse yet and all that, but it's just on this algorithm here. That's why I'm mentioning it. Don't fret over it, okay? Now stick with me for a few more minutes. I know it's been a long day, but we need to get some stuff finished up or else we will never get caught. We'll never.
So you said the amiodarone is 150 milligrams per 10 minutes?
It's 150 milligrams over 10 minutes. Followed by maintenance of 1 milligram per minute for the first 6 hours. Alright. So here's a little bit of an Here's a little bit of an overview of some of the drugs. I'm not going to spend a ton of time here, but adenosine should be used when the tachycardia algorithm, when vagal maneuvers fail to terminate, stable narrow complex SVT. Alright, needs to be given as a rapid IV bolus. It interrupts reentry pathways causing that are through the AV node and restores sinus rhythms in patients with SVT, allegedly. So if you didn't get it earlier, your first dose, 6 milligrams IV, followed by 20 milliliters normal saline. Your second dose, 12 milligrams rapid IV, followed by 20 milliliters. Alright, diltiazem is a calcium channel blocker. So one of the things it does is it slows conduction at the AV node. It also decreases automaticity of ectopic foci. What do you think, if I'm decreasing automaticity of ectopic foci, what do you think's the goal there?
Get the heart back in rhythm.
Yeah, to get the heart back in rhythm, but in particular, at that ectopic foci, why do I want to give something that's going to decrease automaticity?
So it can't contract itself?
Yeah, so it's going to slow down its conduction, and hopefully it will convert. It also decreases the velocity of cardiac contraction. Velocity of cardiac contraction, that's going to be dromatropy. Velocity. One of the things you've got to be very careful of, and I would definitely know this, is that cardism can cause pretty significant systemic hypotension. So it can cause you to drop your blood pressure very quickly. And I told you the dose earlier, but it's 0.25 milligrams per kilogram IV. Alright? Beta blockers. So the AHA recommendation on the algorithm is Sotalol. It's a non-selective beta adrenergic blocking agent. So it's non-selective beta, meaning it'll act on what?
Beta 1 or beta 2?
Yes, beta 1 or beta 2. And it's also a type 3 antidysrhythmic. Y'all haven't went through the antidysrhythmic types yet in cardiology? Alright. Y'all will. Again, I mentioned you might see labetalol, I think is a more common one in Alabama now. Amiodarone, class 3 antiarrhythmic agent. So there's two different dosages. Just worry about the tachyarrhythmia dosage right now. 150 over 10 minutes. Because we will get in cardiac arrest, but we'll talk about that next time. Alright, I need to talk about one more thing. We'll see it again when we get to 12 lead, but pre-excitation. What does the AV node do? What's one of his main jobs? Y'all told me earlier. What? No, I think you said it.
I said it holds for a minute.
Yeah, it holds the conduction. So it's supposed to hold the conduction to keep the ventricles from depolarizing as quick, right? Pre-excitation is early depolarization of ventricular tissue. So some people may have what's called Wolff-Parkinson-White or LGL, Lown-Ganong-Levine syndrome. The WPW is more common. They actually have an accessory pathway that conducts electricity to the ventricle. It bypasses the AV node altogether. So if the conduction is not going through the AV node, what's going to happen? It's going to go straight to the ventricle, right? It's not going to be held up. So you're not going to really have much of a PRI. Alright? If you remember, your PRI is from the start of the P wave to your QRS. Okay? So somebody that has a pre-excitation syndrome like Wolff-Parkinson-White, they will have what's called a delta wave. And all this is indicating is the atria has contracted here and it goes straight into the ventricle. Instead of if it was a normal sinus rhythm right here, the atria would contract and then it would be held up for just a moment at the AV node and then it would go. Y'all see the difference there? So that's all that hook is that it's going straight into the ventricle. It's bypassing the AV node. That's called a delta wave right here. So a couple things that are characteristic of Wolff-Parkinson-White syndrome.
What was the other, there's two...
Lown-Ganong-Levine syndrome.
Yeah.
We'll talk about it a little bit more in a couple of modules away from now. Alright, but the delta wave, the QRS is greater than 0.10 seconds because they're getting stimulated early, and your PRI is pretty much non-existent, but it's very short. Okay? So here's a Wolff-Parkinson-White conduction versus a normal conduction right here. And basically what's happening is that when conduction's going through, typically it stops at the AV node. What's happening now though is that there's an accessory pathway that instead of stopping at the AV node, it just goes straight on down to the ventricle.
So the delta wave is more of a curved wave instead of
Yep.
straight down, negative.
Right. So what you're going to see is it's going into the ventricle instead of having just the flat line right there. One thing to know though, two things to know about Wolff-Parkinson-White: the delta wave, what it is, and then also know that somebody with a preexcitation syndrome, such as Wolff-Parkinson-White, is predisposed or has a higher incidence of tachyarrhythmias. So they go into like SVTs more often. Somebody that has Wolff-Parkinson-White will typically know they have it. Not always. Okay? And that's not the last that we've seen of Wolff-Parkinson-White, but I wanted y'all to at least know about that right now, alright? So there's a couple of more things and then we're done. I'm not going to do junctional today because we're almost out of time. Your clinical significance of atrial rhythms. There's not really anything that's typically clinically significant about WAP or MAT unless the rate gets very high with MAT. PACs, where we really start getting concerned if we start seeing premature complexes is if they become real frequent, because what that's telling us is that there's something stimulating or irritating the heart cells. Okay? A flutter typically is well tolerated. We worry about treating it if we start seeing a very fast ventricular rate with it. The treatment would be to decrease ventricular rate. You would just follow the tachyarrhythmia protocol.
She said typically well tolerated unless what?
Unless a very fast ventricular rate is associated with it. Alright. Atrial fibrillation. If they got controlled AFib means they're on medication for it. It is chronic. We don't do nothing for it. It's probably just going to be something that you saw if you put them on the monitor. Okay? Rapid or uncontrolled AFib, decrease the ventricular rate if possible. If we could just decrease the ventricular rate without really converting it, that would probably be helpful. So you could give like Carotid. But if it converts, if they're unstable, then that's okay because we're going risk over benefit here. And the risk is very great of them actually going into cardiac arrest if they stay in a non-sustained AFib.
Bless you.
Bless you. Patients are at risk of atrial and systemic emboli due to the increase in cardiac output or loss of posterior kick.
Bless you.
Alright? And then your SVTs, again, it's going to depend on what is their stability. Is it causing them to be stable or unstable? Hemodynamically. Okay? Alright. I got a few review strips for us to look at. Then we'll get out of here. Do y'all need a break before we review them? Or do y'all want to go on and go through it?
Go.
Alright. What's my rate on this? 50? Regular or irregular? What?
I was gonna say regular.
Irregular.
Is it irregular? Who said that?
Yes, irregular.
Okay. What does your P waves look like?
They're different.
They're not inverted.
Some are pointy and some.
Yeah.
They look different.
Some are pointy and some are rounded.
Alright. So you could put differing in shape. My PRI,
Non-existent?
is existent, but it's another term. Huh?
Inconsistent.
Variable, inconsistent. Variable is a better term to use. My QRS complex, it looks pretty normal. It's got this big long loop down here, and that's because of possibly digitalis toxicity. But my QRS itself is about 0.08, 0.10, somewhere around in there. All right, what is it? What? Look at you guys. I'm gonna make rhythm interpreters out of y'all yet. Alright, this next one. Remember what I said about this rhythm earlier? When you just throw it up there, it kind of just jumps out at you. Does it do that now?
Mm-hmm.
That y'all seen it a little bit?
Yeah.
Yeah. So just right off the bat, you can tell it's what? What's my ratio here? 4 to 1. So when we do our A flutters, we want to get an atrial rate. 3, 4, 5, 6, 7. 7 times 4, 28.
Yes. So 30?
310.
Yeah.
My atrial rate's 310. My ventricular rate is 1, 2, 3, 4, 5, 6, 7, 80. Is it regular? I'd say it's pretty regular. I can't get a PRI. I'm going to describe my P waves as flutter waves. My QRS complex is about 010. So I'm going to call this atrial flutter 4 to 1.
Are you gonna ask for that?
Mm-hmm.
So we need to add the ratio into it.
Yep.
Okay.
What do y'all see with this one?
There's an arrest.
It's not sinus arrest. Look at this is a fibrillating baseline right there.
Okay.
So this is one of those things where you're gonna need to measure your rhythm. Like, is it regular or irregular? Because it is, you would even notice that between that and between that is different. So it's irregularly irregular. I've got a fibrillating baseline. What is it?
AFib.
AFib? Or atrial fibrillation?
Fibrillation.
Alright. This one's a little bit more tricky, but it may not be. What? Where is it?
Right there close to the end, like the second, in the middle between the last three.
There's two.
Alright, right here. One more too. What?
Go left 3.
This one?
Mm-hmm.
Alright, and so is this a compensatory or non-compensatory pause? Now I'm not going to ask y'all to do it on the quiz to tell me, but
Non.
it's a non-compensatory because it kind of has to start back over, and then that PAC shows up again. All right. How often does that PAC show up?
Every third.
So that would make it what? Trigeminal. So I would call this a Sinus rhythm with trigeminy premature atrial complexes.
The rhythm's irregular.
But
The rhythm's irregular.
it is irregular because your RRs are disrupted. Alright, let's look at this next one. What's my rate? What is it? 210? What about my rhythm? Regular, irregular? It's regular. Do I have a P wave?
No.
So I don't have a PRI. My QRS is about, what do y'all measure it as? I got about 0.12. But it's narrow complex, no P wave, rates way greater than 160, so what is it? Supra-ventricular tachycardia. Alright. What's my rate here? 50? Is it regular or irregular?
Irregular.
Irregular. But it's really irregularly irregular, right? Do I have a P wave?
No.
So then I don't have a PRI, my QRS. Um, 0.08 or so. But it's got a fibrillated baseline, it's irregular, and it doesn't have a P wave, so what is it? What? Atrial fibrillation.
I thought you said the P wave is non-existent and PRI is non-existent.
That is.
Are you okay in our workbook if we abbreviate?
Sure. Just not on your quiz.
Yes, sir.
Do I have an underlying rhythm? It doesn't look just like your textbook, but it is a underlying sinus rhythm, but I've got a little something extra in there. Where is it?
PVC.
PVC? PAC. Right here. But then all of this is my underlying rhythm. So I call this sinus rhythm PAC. And I only have one PAC on this strip. There it is again. Atrial floater. What's my ratio? 3 to 1. Looks like it got a little bit kind of messed up right in there at the beginning. But it is atrial flutter. Alright. What'd you think about this guy? I don't know what SVT is.
Supra-ventricular Tachycardia.
Why?
Because of the narrow complexes and it's fast.
Narrow complex is fast, but sinus tachycardia can be narrow complex and fast. No P waves, and it's greater than 150. What do you got here?
We don't have that one.
You don't have this one?
No.
Okay. So my P waves look different. I got at least 3 different P waves. My rate is 1, 2, 3, 4, 5, 60. What? Somebody say it so we can go home.
Wandering atrial pacemaker.
Wandering atrial pacemaker. Okay. So, next week, we got a good bit crammed in, but junctional rhythms won't take a real long time. Ventricular rhythms will take a little while, and we might get to AV blocks, but we're on the road to rhythm interpretation. Are there any questions?